الو 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 السلام عليكم، تسمعيني سحر؟
عليكم السلام دكتور. نعم
تسمعيني تمام؟
نعم.
وشلون نسوي؟ مسوي شيء؟ ها؟ شير سكرين مسوي المفروض؟ لا مسوي شير سكرين. زين شلون اسوي هذا؟ على هذا بريزنت. لا بعد تجي. لحظة بس. تمام السكرين واضح؟
نعم دكتور واضح.
أوكي. نخلي الصورة هالشكل نبقيها وتسوي تقديم، يعني صورتي موجودة والبرزنتيشن كمان موجودة. أقدر أشيل الصورة مالتي أي وقت. تمام؟
هذا اذا ضوجت اذا عم تشوف السلايد ضوجت بس تشوف منها صح ما يحتاج اذا ضوجت تدوس هاي
بس ادوس هاي بس هاي
اي من مالت
دكتور
نعم
إذا حضرتك جاهز نبلش؟
دقيقة بس دقيقة واحدة بس.
اوكي
ممكن نبلش هسه.
نبلش؟
نعم اكو حضور، موجود حضور حاليا؟
نعم دكتور موجودين.
اوكي
اوكي
يس.
I think we start the webinar now. Good evening everyone, and hello everyone and welcome to today's session. My name is Sahar from Triangle Medical Trading and I will be the moderator for tonight's session. And our topic of course is vitamin D beyond calcium and bone metabolism. Tonight's program will be around 40 minutes of presentation followed by 10 minutes question and answer. And now I would like to introduce our esteemed speaker, Dr. Dhafer Abdulatif Mahmoud. Dr. Dhafer is a consultant internist and endocrinologist, currently practicing at Oriana Hospital, a specialized medical center, and NMC Medical Center in Sharjah. Dr. Dhafer has more than 30 years of experience as endocrinologist and internist in hospital and clinical setting, which includes also working as a consultant endocrinologist and internist and associated professor at City Teaching Hospital at Baghdad University in Iraq. Dr. Dhafer is a graduate of Baghdad University with a Bachelor of Medicine, Surgery, and postgraduate diploma in internal medicine, and doctor is a fellow of the American College of Endocrinology, also a fellow of Royal College of Physicians, and also he's a certified Arab board licensed internal medicine. And I would like to inform all of our attendees that a recorded version of this webinar will be available on YouTube, so we can share it with you after the event is done. Also, the presentation, of course, as we said at the beginning, will be followed by question and answer session. So please go ahead with any questions you have at the end of the presentation. And of course, for those of you who are joining us now, welcome as well. And Dr. Dhafer, the floor is all yours, so we can begin now.
Thank you, Sahar, and thank you for Triangle giving me this opportunity to present my talk. Assalamu alaikum. Good evening, everybody, my colleagues and my friends. We are going to speak within the next coming 40 minutes or 45 minutes about the vitamin D. We are going to concentrate on the extraskeletal muscular effect of vitamin D and vitamin D deficiency and prevention. With no further ado, we are going to start our talk. This is my content of the presentation. We are going to go rapidly with the history of vitamin D. Whistler and Glisson, the 16th century, first discovered the disease rickets, but they didn't know the etiology of the disease, in fact. And then Sir Edward Millenby in 1918, concerned with the high incidence of rickets in UK, especially in Scotland, especially because of the weather in Scotland, and they call it at that time the English disease. And he thought that this is secondary to dietary deficiency, and he made a very clever trial by feeding the dogs in Scotland with a diet equal to the Scottish diet, with which is fortified with oats, and keeping the dogs out of the sunlight. And he found that these dogs developed disease identical to the rickets of the human being, and this disease had been cured by feeding the dogs by cod liver oil. And he therefore assumed that substance in the cod liver oil which treating or cure this problem. And he thought that this product is the vitamin A, because he knows that vitamin A is the well-known vitamin at that time in cod liver oil. Then after that, the Malcolm, which left Wisconsin University and moved to Johns Hopkins University, he correctly concluded, he thought that this is the effect is secondary to vitamin, or substance, not a vitamin A, but a vitamin D. Professor Harris Steinberg, and also is in the Wisconsin University in 1916, mentally made a connection between sunlight and calcium retention. And at last, Windhouse, he succeeded in isolation of both vitamin D2, and then after 1 year in 1937, isolation of vitamin D3. This is a very short history about the vitamin D and its isolation. The main natural source of vitamin D is the vitamin from the sun, and this is because of the effect of the sun on the dermal formation of the vitamin D3, and this constitutes about more than 80% of the daily vitamin produced in the body, while the intestinal nutritional absorption of vitamin D making less than 20%. And most of the diets are deficient in vitamin D, unless there are some of the oily fish and some of the salmon, but the fortified milk and the bread and cereals may contain some amount of vitamin D, which may be needed for the daily requirement, but is not enough for to optimize the daily requirement. The main vitamin D preparation are available in two forms: the vitamin D3, which is the cholecalciferol, which is equal to the natural vitamin D produced by the body by the effect of the sun on the dermal tissues, and the ergocalciferol vitamin D2, which is the plant-derived vitamin D. Vitamin D3 is better for the replacement therapy. We're going to see it in the coming slides because of several reasons, and because vitamin D is having high affinity to vitamin D binding proteins and vitamin D receptors, both in the muscle and in the whole part of the body. Vitamin D3 also have a longer half-life, and also it is more than 80% more potent in raising and maintaining the 25-hydroxy vitamin D concentration, which is really needed for the screening of the vitamin D level in the body. Vitamin D3 produces 2 to 3-fold greater storage of vitamin D than does the ergo or the equimolar vitamin D2. It is well known that vitamin D deficiency in all over the world is a pandemic, and especially in our area. And this is one of the slides showing the DHA Better Health magazine, which announced that in 2017 that more than 85% of the population of the UAE population and residents, they are at a high risk of vitamin D deficiency. In Abu Dhabi and Al Ain, both children and adolescents, with this study shown that vitamin D deficiency prevalent ranging from 30 to 65%. So also in the university students, this screening shown that both male and female having vitamin deficiency in the range of 85%. So what are the presenting features of vitamin D? Do those with the vitamin D deficiency, they present with certain presentation? Although vitamin D, as we said, is epidemic, but most of the vitamin D deficient people or populations are in the subclinical or asymptomatic to start with. Only especially affecting this vitamin D deficiency affecting the special populations such as the elderly population, women of childbearing age, and infants and children, especially those with the dark-skinned population and with low sun exposure, mostly seasonal in some of the cold areas with the low sun exposure, and some patients with special medical problems. Also, they are subjected to vitamin D deficiency, such as patient with the fat malabsorption, patient with the chronic liver or kidney problems, which affect or interfere with the 25 and 1-alpha hydroxylation of vitamin D, both in liver and kidney respectively, and vitamin D resistant rickets or patient on long-term anti-convulsant or corticosteroid which interfere with the vitamin-dependent calcium absorption. All those populations are at risk of development of vitamin D, and the consequences of vitamin D deficiency start by reduced intestinal calcium and phosphorus absorption, leading to hypophosphatemia, then hypocalcemia, leading to secondary hyperparathyroidism, leading to bone demineralization, osteomalacia, rickets, depending on the age of the subject affected. Followed by some of those people, they have also bone and muscle defects with reduced immunity, which may be complicated by increased risk of infection, especially pneumonia, and immune response alteration, making the subjects prone to further medical problems such as diabetes, especially type 1 diabetes, multiple sclerosis, psychiatric problems, and some of the malignant diseases. Mostly vitamin D is asymptomatic, as we said, although it's a pandemic. Only in severe and prolonged vitamin D deficiency symptoms are evident, ranging from muscle aches and pain, bone pain, symmetrical bilateral proximal myopathy with frequent falls and physical impairment. In this situation, I still remember one case which had been referred to our hospital in Al-Qasimi Hospital. This is 10 years back when I practiced in Al-Qasimi Hospital. These young girls had referred because of the tetraparesis or tetraplegia, and they thought that there is a central neurological deficit for which they referred the patient for the further CNS referral and advice with the request for doing MRI for the spine and the brain. And after the full investigation, she had been found completely normal. She's only complaining of severe and prolonged vitamin D deficiency. And after vitamin D replacement with the calcium, all the signs, symptoms improved, and she can walk and became completely normal within few days from the therapy. Most of the scientific and the clinical societies, they don't recommend universal screening for vitamin D. But if we look to the individuals at risk, as we discussed previously, at risk of development of the vitamin D deficiency, apart from the specific medical conditions which affect the vitamin D absorption, as we said, and metabolism, which is very widely ranged, like chronic liver disease, chronic kidney disease, cholestasis, chronic nephrotic syndrome, pancreatitis, cystic fibrosis of pancreas, inflammatory bowel disease, celiac disease, amyloidosis, malabsorption, and post-bariatric surgery, which is a very common surgery now because which is need for the improvement of weight or treatment of type 2 diabetes, and those on specific medications like steroid and anticonvulsant. In addition to, it may include a wide range of even normal subjects, taking in consideration that vitamin D deficiency, mostly asymptomatic to start with before development of the bone and muscle complications and other further complications. There are not yet broad consensus on what constitutes vitamin D deficiency. Different organizations, including Endocrine Society, Mayo Clinic, and American Association of Clinical Endocrinologists, have slightly different definitions for the vitamin D deficiency based on serum level of 25-hydroxy vitamin D. But almost there is a global agreement manifest that the range of the severe vitamin deficiency in the range of less than 10 nanogram per ml and insufficient or moderate deficiency between 10 to 30, and optimal vitamin D is above 30 nanogram. So globally agreed that any patient with vitamin D, 25-hydroxy vitamin D, less than 25 nanogram per ml, needs vitamin D therapeutic dose replacement, depending on the level and the clinical presentations. While vitamin D more than 50 nanogram per ml needs maintenance dose replacement, vitamin D more than 150, we should stop the vitamin D replacement. We check for the calcium level and features of vitamin D toxicity. As we said that the best vitamin D for the replacement is vitamin D3 because of the criteria and of the vitamin D3 superior to vitamin D2 in the binding protein receptors, and also the increased affinity for increasing 25-hydroxy vitamin D, and also for the T2-3 increase fold for the storage of vitamin D in the body compared to the vitamin D2. Alpha-calcidol, the 1-alpha dihydroxy polycalciferol vitamin D, and calcitrol have no routine place in the management of primary vitamin D deficiency and only reserved for use in patients with chronic renal diseases such as stage 3 or 4 with the estimated GFR less than 60 or 30 ml per minute actually, chronic liver disease, and in cases with hypoparathyroidism. This slide shows the cascade of the activation of vitamin D, which follows a multi-steps pathways involving UV irradiation of the skin. The melanin content of the skin is another determinant of the efficiency of the first step in the activation of the biochemical cascade. And then two phases of hydroxylation, 25 and 1-alpha hydroxylation in the liver and the kidney respectively. Vitamin D is a fat-soluble substance with a half-life of approximately 3 weeks in the 25-hydroxy vitamin D stage and only several hours at the 125 dihydroxy vitamin D3, which is the active form. That's why the 25 hydroxy vitamin D is used for the vitamin D deficiency screening because of its long half-life. Vitamin D solubility results in higher dosage required to achieve normal blood level in obese people compared to those with normal people because of the fat solubility. A diagrammatic representation of the vitamin D based endocrine system. This is a very, let us say, simplified diagram for the endocrine activation of vitamin D and signals. The calcium sensing protein in the parathyroid and the parafollicular thyroid cells of the are shown as a thermometer. So slight hypocalcemia stimulate parathyroid hormone secretion that signals specific enzymes to synthesize 125 dihydroxy vitamin D3 that directly affect calcium metabolism in the intestine, kidney, and bone to normalize the serum calcium. Then feedback suppression of the parathyroid hormone synthesis and secretion because of the active 125 dihydroxy vitamin D is shown in this diagram. Then calcitonin is secreted by the parafollicular cell of the thyroid in response to the hypocalcemia. It suppresses bone resorption and increase renal calciuria. This summarized to us the endocrine effect of the thyroid and parathyroid in maintaining the calcium level in the body and in the activation of vitamin D. The list of diseases allegedly associated with vitamin D deficiency is subsequently rapidly expanding. Researches into the biochemical actions of vitamin D3 in the human body has been an area of intense interest during the past decades. This comes on as no surprise, as it has been demonstrated that vitamin D3 influences the functions of over 200 genes of the human genome, directly or indirectly, increasing the susceptibility to a wide range of abnormal tissue reactions when it is deficient. Besides the vitamin D3 receptors in the intestine and bones, vitamin D3 receptors have been demonstrated in the brain, prostate, breast, colon, cells of the immune system, vascular endothelial, and the cardiac muscles. The following brief overview focuses on the recent advances and controversies in the study of diseases which associate with the vitamin D deficiencies, apart from the other deficiencies. So we start with the vitamin D skeletal effects and musculoskeletal effect. The role of vitamin D in the maintenance of the calcium balance of the skeleton is a classical activity which has been researched exclusively for the last more than 70 years. The mechanisms entail its promotion of calcium absorption in the intestine and facilitate the proper function of parathyroid hormone, thereby maintaining basic metabolic activities requiring adequate serum calcium and phosphate concentrations. The impact of vitamin D deficiency is well known and manifests as rickets in children and osteomalacia after skeletal growth has been ceased, with possibilities of bone demineralization and multiple fractures. As part of the musculoskeletal effect, generalized and proximal myopathy with muscle pain and frequent falls, or even para or tetraparesis or paraplegia or tetraplegia are well presented for the secondary to the severe and prolonged vitamin D deficiency. Osteoporosis is characterized by low bone mass, micro architecture disruption, and increased skeletal fragility. And the fractures of multiple bones, which have been designed to prevent and treat bone losses, and that's why vitamin D had been designed to be treated the postmenopausal women and elderly the subject to prevent secondary osteoporosis and the multiple fractures. The first step in the prevention of treatment of osteoporosis is ensuring adequate nutrition, particularly maintaining an adequate intake of calcium and vitamin D3. We are going to go on little bit details of the extraskeletal effect of vitamin D, and we're starting by one of the very debated role of vitamin D deficiency. And most of the physicians relate vitamin D deficiency to be a disorder of musculoskeletal system, rickets, as we said, rickets in children and adult, osteomalacia, and most physicians do not appreciate the role of vitamin D deficiency in predisposing the development of diseases such as cancers. Epidemiological data shows an inverse relationship between vitamin D level and breast cancer incidence. Low vitamin D intake has also been seen in colorectal carcinogenesis, also have been documented in patients with the prostatic cancer, ovarian cancer, as well as blood dyscrasias such as non-Hodgkin lymphoma or multiple myeloma. This doesn't mean that vitamin D should be recommended for malignancy prevention, but larger randomized clinical trials should be undertaken in a human to establish the role of the vitamin D supplementation in the prevention and treatment of prevent the increased risk of vitamin D and cancers. Vitamin D has a profound effect in the immune system. As we said, it affects the immune system and development and severity of rheumatoid arthritis, systemic lupus erythematosus, and development and severity of multiple sclerosis and systemic sclerosis. Vitamin D mitigate the symptoms of multiple sclerosis and systemic sclerosis and prevent disease progression. So also vitamin D deficiency encountered in patients with inflammatory bowel disease and Hashimoto's thyroiditis. So vitamin D is required for prevention and treatment of several autoimmune diseases, including even type 1 diabetes, as you are going to see in the coming slides. Several evidences and trials confirm the association of vitamin D deficiency and different autoimmune diseases, as we said, and in case control study of 7 million US military persons, high circulating level of vitamin D were associated with a lower risk of multiple sclerosis in those recruited US military persons. Similar association have been described for vitamin D levels and rheumatoid arthritis. Regarding vitamin deficiency and type 1 diabetes relationship, as we said, in a study of more than 10,000 children, daily vitamin D supplementation with doses of 2,000 units per day was found to be associated with a 78% risk reduction of development of type 1 diabetes compared with the supplement with the lower doses of equal children. A meta-analysis of 4 studies of a large cohort of children receiving vitamin D supplementation demonstrated a 29% reduction in the risk for development of type 1 diabetes compared to non-supplemented children. This study, which had been published in Lancet in November 2001, is a birth cohort study in which all pregnant women, more than 12,000 pregnant women in Oulu and Lapland in northern part of Finland, who were due to give birth in 1966, were enrolled in this study. Data was collected in the first year of life about frequency and dose of vitamin D deficiency and supplementation, and the presence of suspected cases of rickets. Our primary outcome measures not the rickets development, but the diagnosis of type 1 diabetes by the end of December 1997. This means that this is followed for the around more than from 1966 to 1997, about the end of 30 years. The result and conclusion of the study is that the dietary vitamin D supplementation is associated with a risk reduction of type 1 diabetes. Ensuring adequate vitamin D supplementation for infants could help to reverse the increasing trend in the incidence of type 1 diabetes in susceptible children. This study published in Diabetes 2018, we examined in this study had been more than 8,600 children had been examined at increased genetic risk of type 1 diabetes at 6 sites in US and Europe. And the association between the plasma level of 25-hydroxy vitamin D level and islets autoantibodies, and whether the vitamin D gene polymorphism modify the effect of the 25-hydroxy vitamin D and the autoantibodies, again, the islets autoantibody. We defined as the islets antibody positive as for at least one autoantibody, such as the GADA, the glutamic acid decarboxylase antibody, islets insulin antibody, and islets antibody. Or one or two of these could be regarded to be positive on 2 or more visits. The result of the study showing higher concentration of the circulating 25-hydroxy vitamin D in combination with the vitamin D receptor genotype may decrease the risk of islet antibody in children who are at increased risk for the development of type 1 diabetes, as defined by the HLA genotype or family history of type 1 diabetes. The association between vitamin D and the role of diabetes had been summarized in this slide, that animal models demonstrated that pancreatic insulin secretion is inhibited by vitamin D deficiency. It's a well-known hypothesis. Active role to the vitamin D in the functional regulation of the endocrine beta cell of the pancreas, and based on preclinical studies, vitamin D seems to play a regulatory role in the insulin secretion, beta cell survival, and calcium flux within the beta cell. All these may affect the development of the type 1 diabetes in the susceptible children. This is a slide showing the relation between the vitamin D deficiency and type 2 diabetes, not type 1. And a 10-year study of more than 500 diabetic adults demonstrated an inverse relationship between plasma 25-hydroxy vitamin D concentration, future hyperglycemia, and insulin resistant. Also, the link between hypovitaminosis D and adiposity, diabetes, and calcified atherosclerotic plaque has recently been demonstrated. These findings can partly be explained by the propensity of vitamin D to dissolve in the body fat, rendering low concentrations of free vitamin D available for metabolic activation in obese people, subjecting those obese people to vitamin D deficiency and its consequences. This slide showing the study which published in Diabetes 2008, a total of more than 524 randomly selected non-diabetic men and women aged from 40 to 69 years at baseline with measurement of the plasma 25 hydroxy vitamin D and IGF-1, insulin growth factor 1, oral glucose tolerance test, lipid, insulin, and the blood pressure measured, and metabolic syndrome-like features all had been studied in this study. Derived at baseline and at 10 years of follow-up, it has been found that there is an inverse relationship association between the serum vitamin D concentration with the future glucose level and insulin resistant in a prospective population-based studies. Higher baseline of vitamin D associated with significantly lower future hyperglycemia, insulin, and positive HOMA test, HOMA insulin resistant test. This meta-analysis by Hugh et al. Published in Medicine 2019. It is a 19 randomized control trials and intervention studies showing that the effect of vitamin D supplementation in type 2 diabetic patients can improve HbA1c, insulin resistant, and insulin in short-term intervention, suggesting that vitamin D can be considered as a therapeutic agent along with the other treatment of type 2 diabetes. As conclusion of the efficacy of vitamin D on type 2 diabetes, vitamin D supplementation on and effect on glycemic control, it improved glycemic control by improvement of the HbA1c, improving HbA1c, the glycemic hemoglobin, and the targeted glycemic control, improving insulin resistant and insulin in short-term intervention. This suggesting that vitamin D can be considered as a therapeutic agent along with other treatment for type 2 diabetes. A report of the National Health and Nutrition Survey, which was based on nearly more than 5,000 participants, found that low 25-hydroxy vitamin D were associated with an increased risk for peripheral arterial disease. Several studies demonstrated a link between low 25-hydroxy vitamin D concentration and cardiovascular events, hypertension, and myocardial infarction, and all-cause cardiovascular morbidity and mortality. Knowledge in this field will undoubtedly progress in the near future for the usage or the indication of the vitamin D in all susceptible subjects. What about the effect of vitamin D and reproductive health? Vitamin D deficiency has been associated with an increased risk of abnormal pregnancy implant leading to obstetric complication, and more than 5 times risk increase for the preeclamptic toxemia and fetal growth retardation, increased risk of all-cause miscarriages and abortions, intrauterine deaths, and all-cause mortalities. However, the effect of vitamin D on reproductive treatment outcomes in couples undergoing assisted reproductive treatment is poorly understood. These are the updated international, we're going to discuss in the coming slide about the updated international guidelines for the indication for vitamin D replacement. And these are the main guidelines, which is the American Association of Clinical Endocrinologists and the National Osteoporosis Society. We are going to see their indications. Endocrine Society prevention recommendation, they recommend that the children in the age between 1 to 18 years, at least 400 for the maintenance of the vitamin D, 400 international units per day needed, and may require up to 1,000 international units per day to achieve the optimal level of vitamin D more than 30 nanograms per ml. While adult between the age of 90 and adult till 70 years, at least 600 international units of vitamin D3 may be needed and may require up to 2,000 international unit of vitamin D3 per day to achieve the optimal level of 30 nanogram. Adult older than 70 years, at least 800 international unit needed, and may require also around 2,000 international units per day to achieve the optimal 30 nanogram per ml. Obese children and adults, those on anticonvulsant medication or on glucocorticoid therapy and on antifungal such as ketoconazole, those that are liable for more risk for and severity of vitamin D deficiency. Those they taking any other medication which may interfere with vitamin D metabolism should be given at least 2 to 3 times higher vitamin D per day to justify the daily requirement and to prevent vitamin D deficiency in those populations. American Association of Clinical Endocrine Vitamin D Prevention Recommendation, they recommend daily supplementation of vitamin D3 at a dose of 1,000 to 2,000 units per day, typically needed to maintain an optimal 25 hydroxyvitamin D more than 30 nanogram per day. 30 nanogram per ml. Higher doses may be necessary in the presence of certain factors, including obesity. As we said, the obese people, they need more doses because of the increase in the fat in those patients and the distribution of the vitamin D in the fat. Patients with the malabsorption, also they need more vitamin D, and certain ethnic groups such as the dark-skinned population. Transplant patients and older individuals may also need higher doses of vitamin D. Vitamin D toxicity. Vitamin D toxicity is extremely rare. It generally occurs only after ingestion of a very high dose of vitamin D and for a long period of time, more than 10,000 to 20,000 units per day for a very long time, may precipitate or may lead to the vitamin D toxicity, especially in patients with the normal gut absorption and those which may ingest excessive calcium with the vitamin D. Vitamin D toxicity can be presented with the clinical symptoms of hypercalcemia, including nausea, dehydration, constipation, or symptoms of hypercalciuria such as polyuria and kidney stones. Patients without primary hyperparathyroidism and with normal function of the kidney, the lowest level causing toxicity elicited till now is 88 nanogram per ml. Most patients with vitamin D toxicity have level greater than 150 nanogram per ml. So vitamin D supplementation with 1,600 units or 50,000 units monthly, this is daily, or 50,000 units monthly, was not associated with any laboratory parameters of vitamin D toxicity and even failed to increase the vitamin D level above the 30 nanogram per ml. So on conclusion for this talk, we are conclude for these stats we presented that vitamin D deficiency is much commoner than we think in the past. And this vitamin D deficiency can be prevented by promoting awareness, especially in high-risk people, which had been discussed, the elderly people more than the age of 60, 65, dark-skinned people, the small children below the age of 5, the nursing women, pregnant women, and so on, or patients who are having malabsorption or other risk for development of vitamin D deficiency. Sun exposure and lifestyle adjustments are not enough to correct the vitamin D deficiency and its consequences. Adequate intake of fortified products and pharmacological vitamin D3 replacement for the deficient and maintaining supplementation is sufficient to improve the vitamin D level. Now we are going to discuss with the coming slide, the one of the hottest topic is the vitamin D immunity and immunity and the COVID-19 infection. This is a picture which had been taken long ago, showing the Alps boundaries that by Dr. Roller Institute, showing that the treatment of pulmonary tuberculosis at that time and other TB diseases done by means of direct sunlight exposure. Those patients spend as much time as possible in the open air, exposed to the rays of the sun, and as part of the vitamin D role in the improving native immunity against any infection. At that time, they regarded see that all of them, they are naked or semi-naked to expose their bodies in the Alps boundaries for the sunlight to improve their immunity by improving the vitamin D in the level. So the vitamin D and COVID infection. Now we are going to discuss the importance of vitamin D. COVID infection by itself is not the most important thing to life-threatening. The coronavirus doesn't destroy the lungs directly, but the over-responsiveness of our immune system leading to the cytokine acute respiratory distress syndrome, e-storm. So the cytokine storms are the major cause of death from coronavirus, COVID-19, and resultant pneumonia. Effect of 125 dihydroxyvitamin D on the T cells include the suppression of the T cell proliferation, a shift from the Th1 and Th2 and development, and also inhibition of the Th17 cell development, and the facilitation of the T regulatory cell and the B cell. All this has been affected by the active vitamin D3. Effects of the 125 hydroxyvitamin D on monocyte and the dendritic cell include inhibition of the inflammatory cytokine production by the monocytes and inhibition of the dendritic cell differentiation and maturation. All this will affect positively the immunity against COVID infection and any infection in fact. Vitamin D also enhances the cellular immunity in part by reducing the cytokine storm induced by the innate immune system. Pro and anti-inflammatory cytokines in response to the viral and bacterial infections are observed in COVID-19 patients. Vitamin D increases the expression of the anti-inflammatory cytokines by macrophages. Also, vitamin D protects against life-threatening acute respiratory or adult respiratory distress syndrome and lung failure through affecting the renin-angiotensin system by suppressing the angiotensin II production, which is one of the main effects of the COVID or the coronavirus on the lung, which producing its effect and sequelae in acute respiratory distress syndrome. We are going to go rapidly through three important studies, which by recently studies of the COVID-19 and the importance of vitamin D. And these studies, which may significantly showing the importance of the vitamin D and management or the patient with the subjected to COVID infection. This is in the Irish Medical Journal 2020, in April 2020, published. Vitamin D deficiency may contribute to increased risk of respiratory infection, including COVID-19. General adult population to be supplemented with the vitamin D to enhance its resistance against COVID-19. The Irish Medical Journal, as I said in April 2020, connection of vitamin D deficiency is thought to be suppressed. This is done through the suppression of the CD26 cells. A putative adhesive molecule to COVID-19 host cell invasion. Vitamin D may also attenuate interferon gamma and interleukin 6 inflammatory responses, both potent protection of proper outcome in critically ill ventilated patients, including those with ventilated COVID-19 patients. The second trial had been in Nutrition 2020 in May 2020. To reduce the risk of infection, it is recommended that people at risk of COVID-19 consider taking vitamin D3. The goal should be raised vitamin D3 concentration in the range of 40 to 60 nanogram or above. This lists some findings for vitamin D supplementation in reducing the clinical effect of COVID-19 infection found from the treating other diseases. Evidence that vitamin D supplementation reduces risk of influenza and COVID-19 infection and deaths by high dose vitamin D. The goal should be, as we said, raising the 25 hydroxyvitamin D concentration more than 60 nanogram per ml. For treatment of people who become infected with COVID-19, higher dose of vitamin D3 may be needed to raise the level much higher than this level. So these are the recommended patients for the increasing the level of vitamin D. This study by the clinical experimental research in May 2020 showed studying the significant ratio between vitamin D levels and the number of COVID-19 cases, and especially the mortality causes by this infection. This slide shows the mean vitamin D levels per country versus COVID-19 cases and mortality per million population. In conclusion, this study showing that we found that a significant crude relationship between vitamin D levels and the number of COVID-19 cases, and especially the mortality, especially in elderly people, is also one of the most effect on the deficit of vitamin D level in those populations. Vitamin D has already been shown to protect against acute respiratory infection, and it was shown to be safe. It should be advisable to perform the deficit studies with the vitamin D deficiency and COVID-19 patient with different degrees of disease severity. These are maybe the last two slides, the vitamin D and immunity. This update, this study had just recently published in a few days back in October 2020 in the Journal of Steroid Biochemistry and Molecular Biology. This study had been done in university hospital setting in Rein Sofia University Hospital in Cordoba in Spain. Out of 50 patients treated with vitamin D, 1 required admission to the ICU. This means 2% of the vitamin D treated patient or with COVID-19, they required ICU admission, compared to 26 patients without treatment of vitamin D. 13 of those non-treated patients required admission. This means 50%. So 2% of the vitamin D COVID-19 treated patients require ICU admission with maybe further need for ventilation, but only compared to 50% of the non-treated vitamin D of COVID-19 patient which need ICU admission. This shows us the importance of the vitamin D in the COVID-19 patients. So vitamin D reduces the risk of ICU admission by 96%. Vitamin D may have a variety of actions on cells and tissues, as we said, involved COVID-19 progression, especially by decreasing the adult respiratory distress syndrome, the effect of the calciferol treatment in the intensive care unit association and mortality rate among Spanish population study in these patients. And in conclusion, administration of high dose of calciferol 25 hydroxyvitamin D3 significantly reduce the need for the intensive care treatment for COVID-19 patient requiring hospitalization due to proven COVID-19. Calciferol seems to have able to reduce severity of the COVID-19 disease. So the vitamin D in COVID-19 management protocol, we are going to see this this is the protocol which is needed for the had been discussed in the Eastern Virginia Medical School, updated September 2020 for the management of COVID-19 as part of other recommendations. We are not going to discuss for the further management of the COVID-19, but as part of the further recommendation of other substances, in addition to the other measures for supplementation regarding vitamin D supplementation. It has been needed that for the prophylaxis against vitamin D, against COVID-19, vitamin D3 in the susceptible or subjected people, vitamin D3 in the level on the dose of 1,000 to 4,000 units per day needed. Mild symptomatic patient at home without any admission, they need replacement vitamin D3 2,000 to 4,000 per day, while the mild symptomatic patient on the floor in the hospital, they need also up to 4,000 units per day. And thank you for your patience, and I am ready for any question.
Thank you very much, Dr. Dafer, for sharing these valuable information with us. Now we can get to the questions from our audiences. If you have the question tab here, you can ask any questions you may have.
seems to be that is very detailed, and either they, I think I suggest that they were satisfied with the lecture without, yeah.
Doctor, we have a question.
Yeah.
Any relation for vitamin D deficiency and dermatology problems? People that might have dermatological problems related to immunity, perhaps?
Well, reviewing the subject, I don't found any vitamin D relation with the skin and the skin diseases, but the skin diseases may affect the vitamin D level. So patient putting any ointments, any sunscreen, or dark skin people with the exfoliative dermatitis or very extensive skin disease may affect the vitamin D level. But I don't think there is any, I didn't come across any affection of vitamin D on the dermatology. If you know anything, Sahar, regarding this, can you help us with this? I don't think I came across, reviewing this subject, I didn't come across. Maybe this long list of other diseases, vitamin D has a very little effect on the skin, but the skin may affect the vitamin D disease or deficiency.
True, doctor. The skin, the people that have the skin could be an effect for vitamin D deficiency, but on the other side, there are some clinical data suggesting a vitamin D relation to actually autoimmune diseases for the skin. We're talking for psoriasis, yes, vitiligo, psoriasis. These kind of problems, there were some clinicals that was done, and when vitamin D was given in high doses as a treatment, it did help with the problems of these patients. That was about it, doctor.
This is maybe something which is acceptable because part of the autoimmune disease. But in a specific, I didn't come across such things, frankly speaking. Yeah.
So we'll just wait for a few more minutes if any other questions are there. Otherwise, we will close the session. Okay, we have one more question. What about vitamin D deficiency and polycystic ovary syndrome, doctor? Have you found any relation there?
Vitamin D deficiency and polycystic ovary. Vitamin D, as we said, it may affect the insulin resistant itself. And insulin resistant is one of the features of the polycystic ovary. So one of the features of one of the causes of etiological cause of polycystic ovary is insulin resistant. And it's very well known that the vitamin D deficiency may increase the risk of the hyperinsulinism and insulin resistant. And it is indirectly may be one of the role for the management of patients with the polycystic ovary, because this will improve the insulin resistant, and this consequently will improve the polycystic ovary. And by the end of the day, we in the management of the polycystic ovary, we want to give something or to improve the insulin resistant. And as we saw on the previous slides, that vitamin D has a very strict and close ratio with the insulin resistant. So I think there is a relationship with the polycystic ovary, and as we said, there is a relation with the even impairment of the gestation or also the progression of the pregnancy, with increased risk of the preeclamptic toxemia and the implantation of the implantation in the uterus. So it is a very vital to prescribe the vitamin D for pre-pregnant, pre-gestational lady, or even during gestation. Those patient, pregnant lady, they have under the high risk of development of vitamin D deficiency and sequelae. So also a patient with lactation. So those lady, they need it in the pre-conception, during conception, and in the postpartum period.
Thank you, doctor. Doctor, we have one more question. In your practice, did you find any difference in the results between using vitamin D3 or using vitamin D2 for treatment?
Yeah, this is I expect this this question. This is very important question. Yeah, vitamin D3, as we said, it is the let us say theoretically, it is the natural vitamin D which is present in the body, and it is the produced by the same as produced by the UV light from the dermal. And as we say, it is more effective, more efficient, and more binding to muscle and receptors. Vitamin D2 can exert its effect, but it needed maybe higher doses, may need a longer time for exerting its effect. And its effect on the 25-hydroxy vitamin D level as a screening for the vitamin deficiency, vitamin D3 more effective in that and more restoring the level of vitamin D in the plasma. So we saw that those patients on vitamin D3, they may reach the optimal level of the vitamin D, 25-hydroxy vitamin D in the peripheral blood, with optimal in our daily practice, optimal effect, more than that with the vitamin D2.
True.
Practically, this is in addition to theoretically. It's like we have faced it in our daily practice. Yes.
Okay. If we have no more questions, then I think we can conclude tonight's session. I believe that covers all of the inquiries from the audience. Once again, thank you so much, Dr. Dhafar, for your time and for your expertise. And also, on behalf of Triangle Medical Trading, I would like to thank all of you, our esteemed audiences, for taking from your night and attending with us. I'm sure we have all learned quite a lot of new information tonight regarding vitamin D. And thank you so much and have a good evening.
Thank you so much, Sahara, and thank you for Triangle, and thank you for our audience giving us this very precious time to hear this presentation. And I hope we're going to see you in the near future, face to face, after this era to go. And we hope that it be better than seeing you on webinar. Although the webinar may cover a lot of things, but we hope you're going to see you in the coming near future, and I hope you're going to keep safe at home. Thank you so much.
Thank you, Doctor. Good night.